the afternoon session to State of the Art of Paraesophageal Hernia Repairs. This is a surgical part where we get to just see really pretty pictures. To the gentlemen who really need no introduction because they've been introduced multiple times, I'd like to bring up John Lipham, Trip Buckley, and Phil Woodward, who are going to show us their versions of how to fix a paraesophageal hernia.
No podium, so you just gotta wing it.
Should we hug it out here? Or?
We'll hug at the end.
So we're going to thank you, Gal and Josh, and to Tom and Prakash. This is a lot of fun. We're going to try and do something different with this session. We are going to really kind of just have a conversation between us, and you all are kind of in on it. I have some ideas about some of the things that we should do during paraesophageal hernia repairs, and we're going to hear from Philip and John as well. So we'll get started. But they assured me that they're going to be making fun of me a lot. Something happened.
Sorry, Mark.
Okay. So,
This is right?
disclosures?
Okay.
All right. We're terrible at paraesophageal hernia repairs. Everybody knows, all the surgeons anyway, know this paper. We have to get better. And we really haven't done anything new or crazy different for a long time. There's some sort of tips and tricks that we might all each have and teach each other, but we got to get better at this. And as been mentioned, I mean, this is the Achilles heel. We were just talking about it. I mean, we can do all these great things. We can make Nin's, omega valve. He's in the back there. We can put in a links. But if all this stuff ends up in the chest, we're in big trouble. This has never really made a ton of sense to me, however, meaning you don't see reherniation through the suture line. You don't see it over here. It's at the left cruce from 12 to 6, 12 to 5. So we gather all our data. We always look at it. This just happens to be a poster we presented somewhere. I've used BioA, I've used Phasix, I've used almost everything. And we do okay. This happens to be, pretty large hernias. We were looking at the usual things, and we did pretty well, but we're certainly not perfect. But we can definitely use mesh, and I prefer bioabsorbable mesh versus biologics. I think personally biologics kind of need to go away. So this is a video. This is, they said we got to have a video for this thing. And so this is Charlie Hill, who's, I don't know if he's here right now, but he's at the meeting. I didn't have, the residents don't let me operate anymore. I was in private practice or the military for a long time, but so the residents are like, you're done operating. And so he's our chief resident, and this is how he does it anyway. Hopefully I've had some influence on that, but we got to do a big mediastinal dissection. You need to get way up there. And of course I tell them, based on military, I'm scared of blood. I have PTSD from blood anymore, so I don't want any blood. And I will tell you, I did not scrub into this case until the end of until the mesh. So he's not happy with his link there. He's going to keep going. And I was really proud when I came in and they're like, yeah, we're kind of ready for you with the mesh. But you got to get way up there. I think that really getting that extra intra-abdominal length, not having any tension on the esophagus is important. So here we are closing up the hiatus, so you're going to see different ways of doing that. Yes, John, before you make fun of me, I have moved to the titanium business based on Elisa, who you trained and has joined me now. We scope every case, right? We scope every patient every time. We look at our stuff at the end. So there's our toupee, but you can see here, I mean, this is the weak spot. This is gonna be the bugaboo. So we gotta protect that. Why are there boobs in a foregut talk? I'll tell you. Right here, this is a mesh that one of our plastic.
Your recurrence rate's so high.
Yeah, that could be it. It could be it.
You're in the wrong area of the body.
One of our plastic surgeons was like, hey, let me show you this new mesh. We're using it in breast reconstruction. It is dynamic. The mesh itself is dynamic. We are working on a very dynamic area, right? And so I went to the lab, just joking, that one lab picture was a joke, because that's just the operating room. And so this is this Durazorb mesh, and I'm like, okay, can I use this here? That kind of looks like an esophagus and maybe a diaphragm, just using a light cover. And it's kind of amazing at how conformable this mesh is. And so at first I was putting it in an upside down U fashion, and then I was like, you know, this mesh is so soft, and thank you to SIA, which is the company Surgical Innovation Associates. They're here supporting us, so thank you very much. But it's really soft, and so I started putting it around 360 degrees, which has been a no-no, right? And then started thinking, Dr. Demeester's here. Dr. Demeester, you know, taught us early on that you've got, with the PEL, the frontoesophageal ligament is important in preventing recurrence. And so can we rebuild that frontoesophageal ligament? And so if you notice, I'm looking over here at the left screen, we've got these little leaflets now, the way I've cut this, so that we're going to be laying it directly on the esophagus. Obviously, again, something that would be considered blasphemy, and it may still be considered blasphemy. But I will tell you that we've done this in well over, probably close to 200 patients now, and we're not seeing problems. There's no erosions, and things are looking good. I'll show you a little bit of data in a sec. So we get this in place, and I will say it's a little bit, you know, this mesh is, you gotta really tweak it, and it takes a little bit of time, although hopefully in the future we're working to kind of build this specific mesh, the one where you don't have to show the breast implant picture anymore, that's gonna be designed for this. But I think that getting a 360 mesh, getting a good operation to begin with, 360 mesh, and reconstructing that frontoesophageal ligament is going to be important. Here we're using, this is Eviseal, we usually use Tisseal. They ran out of it, and probably due to my new partner who's too busy, so thanks, John. Anyway, they seem to run out of a lot of things. So we're going to kind of glue this in place as a fixation. And I've been doing glue for a long time with BioA and Phasix, and I don't tack it in or sew it in. I know a lot of the robot people like to go ahead and sew it in, which makes sense, but really haven't had any migration of this mesh. But you notice, again, we're really getting a little bit of length on in terms of reconstructing that frontoesophageal ligament, not only anteriorly, but 360 degrees. So there's leaflets coming out all the way around. Embarrassingly, I got this idea from just opening up a trocar and seeing the way it was cut, and I was like, oh, well, it can accommodate an instrument. Maybe it can accommodate the esophagus. So not a lot of amazing engineering thinking in my brain, but just things that tend to make sense. And so that's really, you know, kind of pretty much the finished product. I don't have any long-term data on this, but I have a little bit of data. This is presented here, and we're going to, you know, really work on getting more data and getting that data out to you. But just wanted to share.
Follow-up 10 months, that's not even data.
I know it's not data, it's early. However, this is the problem. When you have this, we have to have a more reliable way. Our recurrence rates have got to come down. How are you going to fix that? We can do things like mesh and just principles of surgery, and making capnothoraces and doing relaxing incisions. But we got to figure out a way to improve our rates. So I appreciate the time. And this lady happens to be an artist, and she sent every time she comes in the clinic, she brings a new painting. So
That's pretty cool.
Anyway.
I want one of those.
There you go. And Stu, oh man, what happened? I want to say thank you. Where's Stu? Anyway, we can argue and things, but you know, it's all about collaboration. Here's Ken Chang, our service award winner in ROR, working with all of us. And so again, let's just keep it up. Thank you.
I don't know whose bright idea was to put me between two fellows for the American Foregut Society. Dr. Bell's getting old, and I told him, look, we got to name something after you before you get out of here, and all the anatomical structures are taken up, so I came up with the Bell triangle closure, so that this, I'm announcing it, you're now going to refer to this, what I'm going to present as the Bell closure. It started that we were in the operating room, and he was assisting me with an operative closure, and he said, you know, Padawan, the hiatal opening looks a lot like our logo. And I said, you know, Edge, I think you're spending too much time with your Apollo scope in the lab doing colonoscopies on yourself. You need to just concentrate on doing operations yourself. But I think there's some validity to this. You know, when we get in there and we look at the structure, I can, in fact, see this triangle. And I know that's geometry for you, John, and you don't like math, but it's there. Hang on, there's more triangles coming.
No more.
But we believe that when you close things, we shouldn't just come up posteriorly, but we should come in from all angles and work to achieve this. Now, I put this together so I don't have a pretty, I know the triangle's not the diameter of the esophagus, but this is just what we're going to try to show you. So imagine this as I go through this series of slides. So first we start posteriorly. Everybody's familiar with this. Put it in stitches. We like to use Phasix ST. I don't have any mosquitoes in Denver, so I can't use the screen like Trip here. So the Phasix ST bioabsorbable poly-4-hydroxybutyric acid breaks down the CO2 in water if you're interested, but it's just kind of fun and stiff. So we'll use it as strips running up the side. We'll vary the length of these strips based on the size of the esophagus. We'll come up a certain distance, usually 2 or 3 stitches when we're using this 9-inch 2O V-lock suture, and then we'll change. And we'll look and we'll go to the other side. Now what we believe here is that Morrison in 1923 first described a diaphragmatic plication for an eventration of the diaphragm. And if we found that if we are able to plicate that, not only do we bring the anterior posterior together, but the closing of the triangle actually medialized that medial edge as the front of the diaphragmatic crus approaches. So what you're going to see here is we'll put in, depending on the size of this, in this case it's a little larger, we'll put in 2 horizontal matrices with the pledgeted Phasix ST. If it's not a wide gaping hiatus, we still tend to put a suture over here, but this time we'll orientate it in the anterior posterior direction, take a narrower bite through the pledget, a wider bite through the diaphragm, pull it up, and it actually bunches and bulks up that medial edge of the left diaphragm there. Now you'll see us pull this down after we get the pledget through here. Sometimes the fat gets in your way, it can be kind of annoying. If it's a really, really big defect, we can do a series of these and bring in maybe 2 rows. You'll see if we pull that down how it really bulks up and medializes, and then I can come back and I can add in another finish stitch if I don't like the way it's sitting in terms of its bulkiness, and just kind of cover this. And you'll watch we do it here. All right. So you get that nice little support structure. Again, this is all bioabsorbable, will go away. We're using a 2O-ethibond to do this as well. All right, then we come around to what we call the anterior portion, and we can do the same thing. And again, if it's a larger defect, we can do the mattress sutures. If it's a smaller defect, we can do a vertical single one. And if it's just looking like we want to support something, we'll just go ahead and just lay one there without any tension just to absorb. The idea being that I agree with the idea of maintaining the dynamics of the diaphragm. Doing the individual application of the Phasix allows us to maintain space in between so that it's not just a rigid bowl when we're finished closing up everything. I'll skip through this. All right, and then of course we come back posteriorly again, and we finish this up to achieve good approximation. This is one of the things that I know is really different, and all the young people here don't remember it, but I remember the V-necks that we used to leave, and we don't do it. And I remember the first time I went to see the fellows at USC operate, that they went up closer and closer and closer, and it got tighter and tighter, and they said, it looks like we need one more stitch. When we come back down, we run a vertical mattress, horizontal mattress, and we overlap the proline pieces in between to act as further buttressing. And that's our completed closure. I don't have any data to show because I'm not a fellow yet. They haven't given me data yet. We'll see you guys in Dallas.
All right, well, first and foremost, let's forget everything you just heard. I think that would be the safest thing as opposed to making decisions without any data. May get into the American Foregut Society fellowship if you do that. So if I get slides, I'm going to show you what to do. So admittedly, we do have a big problem here. We haven't improved the recurrence rates for decades or at all. And so I think in order to really impact this, we don't need another mesh. We don't need a different way to close the crura. We need to think outside of the box. So at the end of the day, I think the idea here is that I agree with my two esteemed colleagues. If you don't recognize them, that's Philip there on the top with one of his favorite snacks, and here's Trip with prostate issues.
After one of your operations.
Yeah. So anyway, I agree, extensive mediastinal dissection is important, as well as the intra-abdominal length. I think that's clear. What isn't clear and what doesn't appear important, or is at least dealer's choice, as I would call it, is how you close the crura. Whether it's Ethibond or silk or pledgets like we've seen, or mesh or robotic versus lap. None of that has been shown long-term to impact this at all. Because our recurrence rates are still 30 to 50% in the best of hands. And so I don't have time to kind of show you all the data behind the next two bullets here. But reflux, believe it or not, or especially hiatal hernias, seems to be a connective tissue disorder. We don't think about it that way, but it is a connective tissue disorder. These patients are a much higher likelihood of all hernias, groin hernias, incisional hernias. A lot of studies have shown that the problem here is a problem with the production of collagen. And so the next logical step in this is to try to figure out a way that we can improve collagen and wound healing. So here's where it's going to get a little bit weird, so bear with me for just this one slide. But we need something to increase collagen. And there has been something that has been shown to increase collagen and is used in a lot of areas of medicine and surgery, and that's platelet-rich plasma. Platelet-rich plasma has been used for orthopedics, injecting into joints, dermatology for something called a vampire facial, which I got just before coming. And so there's a little bit of animal data to suggest that it may work here for hernias, specifically hiatal hernias. So this is a publication right here, a study by Mark Talamini that was done in pigs, looking at a hiatal hernia model. And what they did is they tried just closing the crura like we always do. They then tried using biologic mesh, like you saw Trip do. And then they tried using biologic mesh along with some platelet-rich plasma. They then sacrificed the pigs, they had a little roast, and what they found was that the platelet-rich plasma increased the pull-out strength of that repair. It also was shown to increase collagen production in the pigs that got the platelet-rich plasma. And other studies have also shown that it increases VEGF, TGF-beta, and neovascularization into that crural repair. And so with that in mind, we decided to go down that pathway to try it in a human. And so I'm going to show you a little bit of that here in just a second. But before we get to that, I need to show you what not to do. So this part's important, so pay attention, get your cameras out if you need to. But here's what's not to do. Now, I won't name the person on the stage that did this, but so here's a giant hernia, as you see, and here we're coming with the harmonic scalpel up along the crura. Now, anybody raise their hand if they know what's directly underneath the caudate lobe? Cava, yes. So what do you do when you make a hole in the cava? You take another bite with the harmonic so you can be sure you're all the way in the vena cava. So I wouldn't recommend doing this. You do have good access here to platelet-rich plasma. But other than that, I don't know, I'd probably stay away from it. At the end of the day, the patient did fine. So here's our first-in-human platelet-rich plasma trial. So we got IRB approval, we got a grant in order to do this. On the back table, we have a centrifuge. We draw the patient's blood. It takes about 60 cc's of blood. We spin it down to get just the platelet-rich plasma. Admittedly, we don't know exactly what we're doing, but our thought was, let's inject some of it into the crura, specifically the superior aspects of the crura where we see that increased recurrence rates. And then our other thought was we do need some sort of mesh to hold the platelet-rich plasma over the rest of the hiatus. So here you're seeing us inject the platelet-rich plasma. It's usually a cc into each pillar or each crura. And then we took vicryl mesh. So if you're not familiar with vicryl mesh, it doesn't hang around for very long. It really doesn't do anything to the repair. We chose that purposely just so we could see the pure effects of the platelet-rich plasma. Now we also found that to get it to become more gelatin-like, we did need to soak the mesh in calcium chloride. So the mesh, which you won't be able to see this, but the mesh is soaked in calcium chloride to help activate the platelet-rich plasma. We weren't sure on the configuration of the mesh. I do agree, I think the mesh does need to be sort of in that downward shape, and I agree with Tripp that I think we need something covering where that frontoesophageal ligament was. So again, this isn't fancy mesh. This is probably like $1.39 at Walmart. We trim it to create that scaffold to hold that PRP there. And then all we do is we just simply squirt the PRP on the mesh and kind of hope that it adheres. If there's one trouble we've had a little bit is just making sure it's thick enough. It does tend to come out a little watery at times. But in this particular case, it was a little better than some of the other cases we've had. The consistency, viscosity of it changes quite a bit from patient to patient depending on a lot of factors, including the medications they're on. So again, we'll coat this entire mesh so we can get that PRP to hopefully activate that whole area for wound healing and improved collagen deposition into that tissue. Because again, as Tripp pointed out, where we're seeing those recurrences is up in this region right here. We almost never see them posteriorly. So again, the hope here is this is going to provide a better seal, I guess, or better healing for the crural tissue in that area. So again, we just continue to soak the mesh the best we can. And then at the very end, you'll see we're going to bring up a partial fundoplication. So all the patients in this pilot trial were done with an anterior partial fundoplication just to keep everything sort of consistent. And so you'll briefly see our version of a Watson fundoplication coming up here. Not that I think the type of wrap matters. So I think that's about the end of our PRP right there. And then, like I said, you'll see the Watson fundoplication come up.
John, I always say that most of what we do in foregut surgery is witchcraft, and you're proving it right here. That's
yep. This is a vampire facial on steroids right here. So I'm just going to let it get to the Watson part real quick.
How much blood do you need to take out to generate that much platelet-rich?
It's about 60 cc's we need to take from the patient. So it's a decent amount to get a decent amount of PRP that we use.
It's easier to get it from the cava.
Yeah, you can get it like I showed you from the cava, but so anyway, that's the Watson fundoplication. So we don't have a lot of data at this point, but we do have some at least preliminary data. The preliminary data we had, we've done 12 patients to date that have actually got the PRP. 8 of them are out a year or more. Now, what's a little different about this trial compared to some other trials you may see, but all these patients are the bigger hernias. It's 5 centimeters or greater to get into the trial. There's no small hernias in these patients. So again, 8 patients are out 12 months. They've all come back for either barium swallow or endoscopy or both. And so far, we haven't seen any recurrences. There's no adverse effects, and we don't see an increased rate of dysphagia in this small little series. Based on that and the safety of that, we were allowed to go forward with a randomized controlled trial, which we just started about 6 months ago. So hopefully by this time next year, I'll have some more significant data for you. So that being said, I don't know if we have time to open up for questions or if we just want to beat on each other or...
I have a couple of questions for y'all.
Okay.
If it's okay.
Sure. You're the moderator. You do what you want.
I have the power. So this was really interesting, sort of 3 different ways and 3 different approaches. And getting to the sort of the pathophysiology and the biology of why we have crural defects, looking at the crura sort of in a more geometric fashion and incorporating technology from different disciplines to try and address the issues that we have. But I think the hallmark of our success in fixing paraesophageal hernias and these large and defective crura is time. We've seen, we don't look at the 12-month data, the 18-month data, we're looking at the 5-year data and the 10-year data. We don't have that data yet, it seems like. So what do you recommend for other people that are looking at what you're doing, the novel way you're addressing the crura, and what's the take-home message you want to give out there?
From my standpoint, I think take-home messages is we do not know a best way to fix a hiatal hernia so it doesn't come back. That data does not exist. We haven't discovered it with mesh. Obviously, we haven't discovered it with PRP because these patients aren't far enough. So at this point, I think to me, the only thing that's important is a extensive mediastinal dissection, plenty of intra-abdominal length, and from there, I don't think anything we're doing currently will change that.
I think, the key is, like you said, is the data. So my practice has been, if we're going to try something new, we do it for 100 consecutive patients, and then we put them in our registry, or our own CQI database, and then we just follow them. And that's why, some of the data before was the minimum follow-up was 30 months. And so we know that, our kind of standard stuff, we got to keep going, because really, it's between 3 and 5 years where all this stuff fails. So that's the data we need. But you got to keep your own data, and you got to get, you have to plan ahead to be able to get it out of something in 5 years, right? So that's what you need to do.
That's okay. I'm still waiting for your REDCap database, but yeah.
So I think in my backyard, I've got monuments to time and pressure. The Rocky Mountains are back there. So eventually we're going to see some recurrences. That's inevitable. So I think one of the messages you need to take home is when you're following the data and you have your database is that you track these patients, because certain numbers of them are going to fall through. There's no other profession where we demand that when we leave an imperfect defect closure, that we demand that it be perfect the whole time. If you're going to hip replacement, you got a time limit on it. So I think follow the patients, instruct them if they have a problem, come back and see you. Don't go see somebody else, come back and see you.
That's good advice.
Can I piggyback on that?
Yep.
As a gastroenterologist, what should my takeaway be from this?
Well, I think what we need to do
aside from it's very
I think what we realize is that the binary way that we look at treating reflux disease is that if the patient ends back up on PPIs, it's a failure. I think there needs to be a spectrum. If we solve somebody's nocturnal regurgitation and they're no longer waking up choking, fearing that they're dying, and they end up taking a PPI if they eat pizza, that's a win. So we just need to reset and recalibrate our expectations and come together and realize that if somebody's going to take PPIs their whole life, that's fine. But if somebody's going to have an operation, they're going to end up taking PPIs every now and then, that's still pretty darn good.
We're beating ourselves up with the data a little bit in that the 50% recurrence rate at 5 years from our only, prospective randomized trial but very few of those patients, small percent, 15%, I think, in that trial, required a new operation. So yes, if you go looking for hernias, you're going to find them. We're all looking for them so that we can give you good data. But very few of these patients in reality need to have a second operation.
A question from the audience.
Christy.
Yes, it's so exciting. I hope it works. We're always looking for the Holy Grail, and it's complicated. But I have a question for your trial. Is it 5 centimeter axial hernias, or is it a hiatal measurement?
It was axial, because we base it on either endoscopy or barium swallow. So 5 centimeters axial, above that, or a true para.
Okay. Can I ask you a favor? Can you collect the day of surgery BMI as well as the hiatal measurements? Just one measurement.
The width?
Yes.
Yeah, we can do that.
Because
BMI
would
we
be
already got.
really good information to have when you're done. Thanks.
Reg?
We have time for one more question.
Yeah. Just a very brief comment to gastroenterologists. We shoot ourselves in the foot when we say it's a 50% recurrence rate. If you have a knee replacement and you can't bend it all the way back like that. Afterwards, is that a failure? If you're walking around okay? Hell no. So we set ourselves an artificial study design goal of 2 centimeters or greater than 2 centimeters as evidence of a recurrence. But clinically, most patients do excellently even at that setting. So it's okay to set a goal to try to improve things, but I think we do ourselves all a disservice, especially to the gastroenterologist. Stu, are you ever going to send a patient for a perisoptic hernia if it's going to fail 50% of the time? If they just have a little early satiety? Hell no. So understand that our clinical results are far greater than what we are talking about here. And we need to stop talking about the worst results at the very beginning. Sorry, Tripp and John, but we got to stop doing that.
All right, I just had a quick question, John. Are you going to biopsy the crura to make sure there's patients that actually have collagen deficits, or are you going to
That study's actually already been done.
Right, but in your patients, are you going to identify them, or are you going to just do everybody?
No, it just came down to the funding we got through the grant. We didn't have that capacity to do that. But that study has been done in patients with hiatal hernias, and they did find that it was 60% lower in type 1 and type 3 collagen in the patients with bigger hiatal hernias.
So if you have a really low recurrence rate, you think that it would be reasonable to try to biopsy those crura to make sure they aren't people that already have a fairly hefty collagen composure already?
I mean, I think ideally if you could get that information back very quickly.
Yeah.
But I just want to push back though a little bit on Reg though. You know, a 50% recurrence rate is a 50% recurrence rate. We're not doing a good job. Now, what I will agree with is the fact that symptomatically most of these patients are fine. Like we said, the need for them to go on PPIs or anything else, you know, is fairly low. But like I said, this is an area I think we can do better, and we need to do better.
Thanks.
Thank you, everyone.
Just
All right,
to make one
thank you.
All right. 1 hour to go. I'm up 6,000 points on Hoover. I post this sucker while the speakers are going. Yes.
I'm going to get
a
it now.
light there. All right. Yeah. Oh, that's good. Hi, everybody. I'm Mike Smith, fellow of the AFS. Very excited about that. Your
Congratulations.
secretary and Hoover user extraordinaire, apparently. And I want to welcome you to the last session. We know that we stand between you, dueling pianos, and a beverage in one or both hands, perhaps other extremities if you so choose. But this is a hell of a session because we have such powerhouse speakers and presenters, and we have probing questions ready. You may have them too, and you're welcome to ask them during our discussion sessions, which we're going to keep on time because we know we want to start the party soon enough. Or you can bring them with you to the closing reception. But Dr. Damani and I are thrilled to be here, and we're going to start off with a guy who needs no introduction because that's been said about him 4 or 5 times already during this meeting. He's not known as Peter Kyrillis anymore. He's just known as, like Madonna, Peter. Come on up, Peter. You need a clicker. Yeah, the podium disappeared. They were already packing this up.
I gave this talk once without slides.
Ladies and gentlemen, Peter Kyrillis.
Okay. Great, so I'm going to talk a little bit about something that you probably haven't heard about unless you're at my other lecture a couple days ago, which is upper esophageal sphincter dysfunction. So let's reorient you to where the upper sphincter is. It's up here, mainly composed of the cricopharyngeus, but not entirely the cricopharyngeus. So when I think of this disorder, I think of it as the upper esophageal sphincter, inclusive of the distal pharynx and the proximal esophagus as well. So that's outlined in yellow there. The other thing on this very helpful diagram here are all those little black dots, because the little black dots are motor end plates. And since we're going to end up talking about Botox injection, those little dots end up being your targets. So what do we know about this sphincter physiologically? Well, it contracts a lot. It contracts to just about any stimulus, whether it's slow distension, rapid distension, stimulating the pharynx, coughing, sneezing, stressing out, and you can even control it yourself to some degree. And what does it do? Well, it prevents you from inhaling air into your esophagus when you breathe. But the other thing that it does, which you don't think about too much, is demonstrated here. Now, this is a force transducer. So that device, you're going to screw those little Teflon balls at the end onto it, and you're going to suspend it just below the sphincter. And watch what happens when you swallow. So you see the hashed area, that's the upper esophageal sphincter. The little bead is that force transducer. And this is the recording of force as you swallow. So that's traction force. It pulls. So when you swallow, the sphincter goes up, it contracts shut, and it grabs whatever's there and pulls it down. That's so that you don't inhale what you just ate. It's a pretty important reflex. But apart from that, what do we know about resting sphincter pressure? Well, it has an active component and a passive component. The active component is mainly the cricopharyngeus. The passive component is about 10 millimeters of mercury, and it's just the elastic property of the muscle itself. Devoid of any of these extrinsic influences, the sphincter pressure goes very low. Hence, there really are no normal values for this. It's essentially 10 plus whatever you're stimulating it to be. So that's contraction. Let's think about relaxation. This sphincter relaxes when you swallow, obviously. I'm not going to talk about that. It relaxes when you burp. And that's what's shown here. So transient LES relaxations, what are these? They are gas venting events from the stomach. You distend the upper stomach, it releases air, you get that nice green common cavity in the esophagus, and look what happens to the upper sphincter pressure. It relaxes completely and it vents air. It depressurizes the esophagus. And how does that work? Well, you get a transient relaxation, you get gas reflux, you get complete UES relaxation, you get gas venting, and then you get secondary peristalsis. And this happens with 80% of transient LES relaxations. These are gas venting events. It gets a little screwed around when you have reflux disease because fluid comes up as well. Their timing is quite variable. They're not linked to the transient LES relaxation. They're an independent event stimulated by esophageal distension. And you can recreate them by injecting boluses of air into the mid-esophagus. So that's the background. And then there's this paper, which was one of the first papers I ever wrote, Dysfunction of the Belch Reflex, a Cause of Incapacitating Chest Pain, 1987. 25-year-old woman, severe chest pain, and upper sphincter dysfunction. She had a long history of gurgling noises in the chest and an inability to belch. Manometrically and radiographically failed upper sphincter relaxation. So study this. This is fluoroscopy. This is somebody who we distended their stomach by giving them a lot of gas-forming crystals. This is a gas reflux event. Look at the diameters of the esophagus here, 3.5 centimeters, 2 centimeters, all the way up to the upper sphincter, but it doesn't relax. Instead, you get secondary peristalsis, milking all that air back into the stomach again. Then it refluxes up again. Hence the gurgling noise, hence the chest pain. So this was the first case of upper esophageal sphincter dysfunction ever published. And it stayed there for a long time, other than a lot of crazy patients sending me emails all the time about how they couldn't belch. It has plagued me for 30 years. And then this came out. This is like in 2019. Robert Bastian there is a otolaryngologist in the Chicago suburbs. And I saw this and I couldn't believe it. Inability to belch and associated symptoms due to retrograde CP dysfunction, diagnosis and treatment. Well, his diagnosis was entirely symptom-based. His treatment was Botox. And look at this, he found 51 of these people in his practice. So there were only 3 published cases in the literature, and then all of a sudden there's this manifesto about 50 of these patients who he treated with Botox injection. And this is their array of symptoms: inability to belch, gurgling noises, chest pain, abdominal pain, flatulence. If you can't belch, it does go somewhere. And they got better and they didn't get worse. So then, shortly thereafter, this paper came out of Amsterdam, and now this is a gastroenterologist, Arjen Breednord, and he actually studied these people and defined them manometrically and with impedance and showed that they couldn't belch. And he devised this provocative test, which is just drink carbonated water, see what happens. And he recreated this whole thing. Then he did the Botox injection, and lo and behold, they got better too. Just about that time, I had a patient who came in and wasn't crazy for once, and she said she couldn't belch, so I did his test, and this is basically what I found. And I'll walk you through it. It's kind of cool. So we gave her the carbonated water. It stimulated a transient relaxation. You pressurize the entire esophagus. In that common cavity, pressurization persists. You get intense upper sphincter contraction, not relaxation, and you milk it down again. So this is from Arjen's paper. And you can see this is the repetitive pattern of up and down, up and down. This is, he did Botox injections to his patients, and this was the pre-post UES basal pressure over here and here. And they got better symptomatically, and he mapped out a number of their symptoms, and they all improved. My patient, by the way, took 2 tries, but she improved as well, and then she couldn't stop belching, but now she's over that as well. So what do we know about the upper sphincter all in all now? Well, resting tone, it isn't very helpful. Maybe it defines globus. Contractile reflexes, well, when they're overly active, you get regurgitation, LPR, bloating with CPAP. When they're underactive, relaxation reflexes, when they're overactive, you get that. When they're underactive, you get this disorder, which I've now named retrograde UES dysfunction. Thank you.
Wow. So I'm glad to know that this is not Bastian syndrome. That you're still in the running here for this, Peter. You pointed out those dots, and you said we got to pay attention to the dots. I'm not sure we came back to the dots, probably because we forced you to do this more quickly than you would have wanted. Where are we putting the Botox if we want to do it right, and who's putting it in? Because I don't know that my anesthesiologist would be particularly pleased with me hanging out at the level of the UES for a while in order to put those injections through. So can you give us a little sense of that protocol, and how do you maximize the efficacy?
Yeah. There are actually a couple, 2, 3 papers written about this now. They're mainly in the ENT literature. Arjen did a bunch. I did one. You image from the hypopharynx, so you don't actually get into the esophagus. You almost get into the esophagus, where you see the bar of the cricopharyngeus go a little bit lateral to midline on each side. The protocol is either 50 or 100 units of Botox.
And 50 on each side, or 25?
25 on each side, 50 on each side. Take your pick. Bastian was doing 50 total. And then there's a fellow in the UK who has a series of another 100 or 150, and he's been doing 100 on it.
Under general anesthesia for airway protection and the degree of tachycardia of the anesthesiologist?
Well, propofol, but yeah, okay. MAC.
Okay, very good. And, we've talked about, and those who read manometries, a non-relaxing UES, people have sort of always pointed it out because the software tells you so, and you feel obligated to at least mention it maybe in the report. And when someone has very poor bolus clearance, now that we do this with impedance, or they've got high volume reflux, we say, oh, this is all right. This is a preventive measure to keep somebody from aspirating. This is a good thing that they're not relaxing. What do you think what's the trigger here? What's the difference? Obviously, one is pathologic and one is probably protective, but what's going on behind the scenes that may explain the same phenomenon going good or bad for the patient's outcome and symptoms?
Well, it's a tricky sphincter. It really is. And it goes back to the original reflexes that I tried to describe way back when. If you slowly inflate the proximal esophagus, it contracts. If you rapidly inflate it, it relaxes. And the threshold for going one way or the other varies from person to person. If it's overly active, then you've got a regurgitator or an LPR patient. That's at least the hypothesis.
So is Dr. Katz coming as the UES, the next frontier for foregut?
We'll grab it.
All right, there we go. Dr. Katz, please.
It's a place for everybody to work. So it's a different kind of muscle than the LES. Is that going to keep the Botox from wearing off, since it wears off everywhere else in the body and needs to be repeated?
Well, that's a great question, actually. And you would anticipate that this treatment effect would only last for 12 plus or minus 6 months, just like it does when it works for achalasia. But in fact, the reported experience, and we clearly need to flesh this out some, is that it persists. And why that is, I don't really know, except there's a lot of learned component to upper sphincter behavior. And maybe just allowing them to belch, maybe they just don't forget how.
I have a question, Peter. So you've described this phenomenon, and injecting the Botox, this sounds like a pretty benign thing for the UES, but patients can have, as you described, this year-long dysphagia from the lack of that grabbing effect. Right?
Yeah,
so
that's why I put that in there, because if you look at all of the series, they all say, well, they had a little trouble swallowing for a while. I just wanted to explain why that would be, but they compensate for it.
Okay.
They compensate for it.
Well, Peter, in the interest of time, we're going to move on to our next speaker, but as President Emeritus, you are allowed to sit on the stage if you would like to do so, and otherwise you can go behind and get started on happy hour, I guess. Would you like to introduce our next speaker, Dr. Damani?
Yes, it's my pleasure to introduce, again, someone who doesn't need introduction, but I will introduce anyway, Dr. Ninh Nguyen. As everyone knows, he's a professor of surgery, chief of the the division of gastrointestinal surgery at UCI, and he's going to talk about something that's near and dear, and he's put a ton of work on this, which is the AFS grading of the EGJ integrity, improving the Hill grade classification.
Are everybody awake? Put your hands over your head and just stretch. There you go. Stretch. We are on the home stretch, okay? I'm a little excited about this presentation.
They still got me out.
I think you're good now.
Yeah.
You can, Rick.
Okay.
Everybody can hear?
Oh, we're too close to me.
Sure.
I think it was the stretch that did it.
Yeah, the stretch did it.
How about now? No? Testing? Testing?
That's good.
All right.
All right. So I'm excited about this project. This is the AFS endoscopic classification of the EGJ integrity. It's a mouthful, but really it's comprised of the work of the Clinical Practice Committee, and that's why I'm so proud of this. And even though I'm standing up here presenting this, these are the real worker who's listed every there, including the rest of the people on the Clinical Practice Committee. Let me tell you about the Clinical Practice Committee. It's being run by myself and John Clark, but we have 91 members and we have monthly meeting. This is our philosophy. If we believe that we are the expert in this foregut space, we need to bring the science. We're not just coming here and regurgitating the science, but we need to bring the science. And it has to be original work from the AFS. We're working on the Hill grade, et cetera, but we have many more work to be done, and it's kind of listed there, okay? So if you want to get involved, we're looking for a few more bright minds. So this is the product also of the Clinical Practice Committee, and this is the labor of love. Why? Because it took us quite a bit of work to get it all together, and this is going to be coming out in the spring of 2023. This is the AFS textbook of foregut disease. And it's just not give you the most up-to-date science out there, but it also give you original work by the author. So I would say this will be the leading book for years to come. Okay, let's talk about this. The American Foregut Society white paper is going to be coming out very soon in foregut. There's a lot of disclosure that was on there, but I can tell you that none of that disclosure impact how we decide to change this grading system. Hill grade was originally described in 1996 by Lucius Hill, a thoracic surgeon, esophagologist. It is a classification of the flat valve. However, clinically, it's not well accepted. I can tell you that. And there's a lot of skepticism about the usefulness or the relevance of this grading system here. So how do we begin this? We begin this through collaboration. And we talk about collaboration here, this meeting, multidisciplinary conferences. But you know where collaboration truly exists? It's inside the OR. And CTIF was the first time where an GI and the GI surgeon are in the same space inside the OR. Because before that, says, okay, this patient goes to you, GI, this patient goes to me, GI surgery, and we separate our way. But this is the first collaboration we work on together inside the same space, right? So now we see the Hill grade that was reported, and then now we see the Hill grade on the laparoscopic view. Might be Ken Chang coming in the OR, or we have training session all the time whereby we have faculty coming in to review the CTIF. So what we found out is that there is a discordance in terms of the reading of the Hill grade and what we found on laparoscopic. So a year ago, I was asked to take a leadership course. And what it says is that, listen, when there are failure or issue that arises, it's not the individual fault. It is the system fault. So what's my conclusion about this? This is not Ken's fault. This is not Ken's fault, right? Because he would read a Hill grade 1, but laparoscopic view, it's like this, etc. So it is the classification fault. So we do recognize that, and then we jump directly on trying to fix this. So this is a Hill grade, very simple. Grade 1, 2, 3, and 4. Everybody kind of knows this, but it does give you the schematic view, it gives you the endoscopic view, and it gives you descriptive view. I'm just going to point over here because it's just easier. So take a look at one. Schematically, that's over-exaggerated. Human anatomy doesn't occur like that. The valve length is not that long, so that's one. This endoscopic view, personally right now, I believe this is actually a Hill grade 3, okay? It's not closely approximated, so this is a very poor example of what a flat valve should look like. I'm going to show you what a flat valve should look like, okay? And then the description, we have to come up with a better terminology. It can't be just ridge of tissue, because that's poor way of describing something, enhance inter-observer variability. 2, and this is the pet peeve, originally, how we actually jump into this, changing the classification, is this Hill grade 2. Take a look at Hill grade 2. This is supposed to be normal. Look, green. This is supposed to be a normal flat valve.
He's a nice guy.
You can see here, very long flat valve here. However, if you take a look at the endoscopic finding here, that's not normal. There is no flat valve here. And you can see here, it's thinning, effacement of the flat valve. And so this is the why we actually initiated upon this changing of the classification. Number 3, it says here, nearly always present. And you can see here, schematic diagram, there is no hiatal hernia present. 4 actually looks pretty good, right? It says here, a hiatal hernia is always present, but the problem, it doesn't give you the objective parameter where an individual says, you know what, that's a 4. So if we believe that GERD is an anatomic disruption of more than just a flat valve, it's actually an anatomic disruption of the hiatus. So upon going to this, there are several principles we have to follow. 1, we minimize major changes that require learning of a completely new classification, because that's too disruptive, because we're so ingrained into Hill grade 1, 2, 3, and 4. And this says it best by one of the reviewer in foregut, I think this is Dr. Phil Katz, fix only what needs to be fixed. Don't go wild on this, just fix what needs to be fixed. And then lastly, make it anatomically accurate and clinical user-friendly. So this is our method, 13-member working group with tasked to do this job. And upon going to this, we decide that, listen, if we're gonna make minor changes, it's just a revision. We're gonna revise the hill grade. But if we're gonna make a lot of changes, this is a new classification. Obviously, you know the name, so there's a lot of changes. And then this is a modified Delphi method. We came up with straw proposal and reiterative multiple subgroup discussion. But before we do that, we have to get the record straight. We can't do this project if we can't agree on this. So we decide to come up with a position statement. This is the AFS position statement on the component of the anti-reflux barrier. We actually don't have a statement that by any society out there. So this is actually the first statement. Okay, so the survey is open-ended question, 24 question on the component anti-reflux barrier, and please comment on the hill grade, both the schematic diagram, the endoscopic image I show you, and the description of the hill grade. So they just said, hey, speak your mind, what do you want to change? What's bad, what's good? So we sent it out to all the clinical practice committee member, the expert panel, the 13 people, and then 47 respondents. That's a pretty good respondents. And you can see here, 21 GI and 26 either GI or thoracic surgery here. And majority, 90% says, hey, this is a worthwhile effort. 90% says, you know what? It's important. So the first thing we work out is the component anti-reflux barrier. This is SAGES, and they said that the exact nature of the anti-reflux barrier is poorly understood. Current view is LES, diaphragmatic crura, and the phrenoesophageal ligament. I like this slide a lot because it says the barrier to reflux is more than LES, and a lot of us shows this. You have seen this, right? In this meeting, Ken Chang have shown this, that the dysfunction, the combination of the two anti-reflux barrier are the LES and diaphragmatic crura. Where is the flap valve? Where is the flap valve? Lucius Hill described the flap valve early on in 1996, and you can see here, it's a one-way flap valve from the greater curve going to the lesser curve here. Blair Joel, Peter Karillas, John Hunter, Swanson has demonstrated that, listen, if you accentuate this valve in anti-reflux surgery, you're gonna get good anti-reflux control. And that has been proven. And then further on, if you disrupt this flap valve by doing a surgical operation such as the laparoscopic sleeve gastrectomy, this is a systematic review, 46 studies, over 10,000 patients. The forest plot demonstrate increased post-operative GERD in 19%, de novo reflux in 23%, long-term prevalence of esophagitis in 28%. So their conclusion is that the sleeve gastrectomy caused disruption of the anti-reflux barrier. They didn't specifically say which of the anti-reflux barrier, but it's likely related to the flap valve. And you know, the flap valve is not new. This is a publication in 1962 demonstrating these are the three mechanisms listed there, and similarly in 1958, kind of showing you that the flap valve is a critical aspect. So we asked all the survey, what are the components that's important? And it listed here. Everybody says, hey, these are all important here. But then we asked, what are the three most important? The one that came out is the LES, the crura, and the gastroesophageal flap valve. Well, what about the rest? The intra-abdominal esophageal segment belongs to the flap valve. They're interrelated. You can't separate one from the other, and same thing with the angle of His related to the flap valve. And the phrenoesophageal is related to the crura. So there you go. This was the straw proposal. And then we went even a further extension saying that, listen, is it a physiologic barrier or is it a mechanical barrier? And this is our result. So the next time you write a book chapter, a paper, anything, you're gonna have to stress the component anti-reflux barrier if you're gonna be talking about reflux. You can't be describing a paper without talking about this. You should quote this. This is AFS copyright, and then you can actually use this If you want to, you can take a picture of this if you want to, but it will be in the paper that's going to be coming out. So this is our final AFS position statement. And I kind of like to look at this in a different way, right? We kind of look at like this because truly, these are all interrelated. If you have a defect in the crura, you're going to have lost intra-abdominal esophageal segment. You lose your LES tone because it's up in the intrathoracic pressure. So I asked Christy Dunn the other night about this question about what if you fix the crura? You're going to fix the hiatus here, and you can see here that that's a Hill grade 3. Will that have an effect on the flat valve just by fixing that? No fundo or anything. And she came up with eloquent answers, says maybe, maybe. But what we found out is that there is an effect. Just by fixing the crura and having an intra-abdominal segment, exactly what we do here, you do fix the flat valve automatically. But it's not long-lasting. That's the problem with hiatal hernia repair alone. It is not long-lasting, but there is an interrelationship between the structure. So there you go. You can see here, if you mess up one of the thing, you mess everything up. But if you restore one thing, you will restore because everything are interrelated, these three. So the new classification, the name is listed there, but we have a shortened version. The shortened version is the AFS HG, hiatus grade, because our focus is not just the flat valve, it is also the hiatus. So this is essentially the summary of what the difference between the Hill, flat valve only. AFS is the flat valve plus the degree of hiatal disruption as measured by the hiatal diameter or axial length. But before we even jump into there, this is critical, right? Because there are so much issue of inter-observer variability in reading of the Hill grade. So we said this is actually the same patient. Same exact patient. This is about 30 seconds later, and this was the original. And you can see here, if you just stay with the left side, you're going to undergrade that, right? And the question, how do you get to the right side here? I have a quick video demonstrating this. And it doesn't take that long. So this entire video is only, I think, about a minute and 30 seconds, but you can see what we're trying to say. For you to get an adequate, you have to do maximal insufflation, flatten out the rugal fold, but you got to do a little bit more than that. You have to do what's called the provocative maneuver, and we'll kind of show the provocative maneuver a little bit. Essentially, the tip of the endoscope is going on to the lesser curve. And we'll go over the nomenclature in a bit, but once you get adequate insufflation here, you have to do the provocative maneuver to see if you can provoke it to induce. And some people says, hey, is that because, hey, physiologically I induced that? No, you did not induce that. You just demonstrating the anatomic defect that's there. And sometimes you can't do it, but sometimes you can do it. For example, here it is. It's called push-off. Get to the lesser curve, push-off. Get to the lesser curve, push-off. And the more push-off you do, you can start to see that the hiatus widen. And look at the involution now. Now you have an axial length of about 3 centimeters, and the diameter is about 2.5 scope. So you can see there is much different than when you just enter. So you gotta have basic endoscopic nomenclature. You can see here anterior and posterior. Lesser curve, greater curve. This right here in the omega shape, and that's how we describe this full lip, and that's the lip of the flat valve, and this is the body of the flat valve, and this is the length of the flat valve. These are the terminology we're going to use instead of ridge of tissue. When you don't have a flat valve, people think this is a flat valve? The answer is no, that's not the flat valve. That's an illusion if you think that is a flat valve. It's called the EGJ mucosa fold. There is no flat valve there. And then if you have these pillar, you got to get your orientation correctly. That's the left crural imprint, and the other one is the right crural imprint. Okay, let's get to the classification. One thing that Lee Swansheim keep asking me, why I don't understand the color coding. The color coding is there. I can't remember now who came up with the color coding. I think it's Barham. But nevertheless, the color coding give you an easy way to say, hey, what's good and what's bad? That's it. Look, is this good? Yeah, it's green. Is this bad? No. Well, yes, it's bad. Okay, what's in between? Yellow and orange. That's it. It makes things so simple. And how is that compared to the hill grade? Look, hill grade, both of these are green, and then you have orange and you have red. There is no yellow. The new one is the yellow one, okay? The new one is the yellow one. And number two, look at the yellow line. Focus on the yellow line. The yellow line is the line of relativity. And what is that? It's the line of the hiatus. Everything has to be relative to the hiatus. So the location of the esophageal gastric junction relative to something, that's called the hiatus. There it is. EG junction below the hiatus. EG junction at the level of the hiatus. EG junction up to 2 centimeter and then above that. So everybody kind of understand that? We did not have in Hill. Look where the diaphragm is. The diaphragm is all over the place. We have here what's called the line of relativity. And here is the final hiatus grade I present to you. You have a laminated version of that when you got in here, but it's hard to understand that by just looking at that thing, right? So that's why I'm here trying to explain to you. Look at this valve. Full, thick lip valve taking the shape of an omega shape. You don't have that when you don't have a full lip. Number two, it's L0, D, and F+, right? So what does that mean? These are the component, axial length, hiatus diameter, and F stand for the flat valve. Either it's present or it's absent. That's it, okay? So everything here is green. The next one, AFS grade 2, is partial disruption. And this endoscopic view, and you said, hey, wait a minute, that's a Hill grade 2. You are correct. You are correct in saying that's a Hill grade 2. We know that. But what we're saying is that Hill grade says Hill grade 2 is normal. It's not a normal endoscopic finding. This is a pathologic finding. Because with Hill grade 2, you lost the intra-abdominal segment, and the D has widened. This is what John Lipham keeps saying, that, hey, there's crural separation. This is exactly what it is, crural separation. You don't have the actual axial component yet. This is a transition between grade 1 and grade 3, which is not available in Hill grade. And you can see here, the minute you lost the flat valve, that's it. So flat valve is either green or red. There's no such thing else. There's no gradation. Either you have a flat valve or you don't have the flat valve. AFS grade 3, moderate disruption, L0 to 0 to 2. So meaning now the axial length here, it's about 1.5 or 2 centimeter. You can see here D, 2 to 3. So you can see the scope here. It's about 2.5. Okay, no flat valve. And then grade 4 is anything greater than 2 centimeter axial length, greater than 3 diameter, and the flat valve is lost. So essentially, this is the AFS hiatus grade with a statement that you have to have full distension and have done the provocative maneuver, and the worst finding determines the grade. So this is kind of summary. I'm not going to go through all this of what are the difference between. This is going to be in the paper. You can read about it. Okay, which AFS hiatus grade associated with reflux but without the presence of hiatal hernia? Which one?
1.
Did you pay attention? Which one?
2.
2. Correct. The AFS 2. What is the first disruption of the EGJ based on the AFS hiatus grade? Which one occurs first?
Hiatus diameter.
B. B. That's correct. Wow, everybody's paying attention. What is the AFS grade, hiatus grade for L1D4F minus?
We just took it up a notch, didn't we?
Yeah, we took up a notch a bit. But once I show you, you're going to say, okay, wow, very simple. Look, okay, L1 is here. Okay, it says, hey, the minute you have axial length, you got to jump. There is no such thing as, wow, I have a good flat valve and a one-centimeter axial length. It used to be that's the case. It doesn't exist anymore. The minute you have L1, it jumped to grade 3. But the minute you have D4, then it jumped to grade 4. And the worst finding determines the grade. So it's truly grade 4. So in summary, we came up with the AFS position statement on the component of the anti-reflux barrier. Please use it. And then now we have a new classification. Your job is to bring this back to your own institution and spread it. You can spread it widely. You can spread it on social media, whatever you want to do. But I think this classification is much user-friendly. So thank you.
I think we can officially say mind's blown, and I'm going to make a provocative maneuver and ask Nin to sit without questions so that poor Dusty Carlson can be done somewhere around the time we're supposed to have the happy hour.
I think that's great. Yes, please find Nin during drinks for questions because we will have some. So Shaheen, yes, it's my pleasure to introduce Shaheen Ayazi, who's going to be talking about magnetic sphincter augmentation. Size does matter, something that many of us are very interested in, and he has some excellent data.
Thank you, Dr. Demane. So the intention of all anti-reflux procedure is to increase the yield pressure at EGJ. By doing so, we would be able to restore the lower esophageal sphincter competency and stop the reflux disease. But a negative side effect of this procedure would be to increase the outflow resistance at the EGJ that would result in dysphagia. As a result, doing anti-reflux surgery is always like walking on a tight rope, trying to make a balance between postoperative dysphagia and reflux control. Walking on that tight rope is much harder when it comes to magnetic sphincter augmentation for several reasons. One is that MSA is associated with a higher degree of restrictive forces at EGJ. There are several studies comparing the two in terms of manometric characteristics of the two procedures. And we know that there is higher outflow resistance after MSA as measured by intrabolus pressure, and less distensibility as measured by FLIP. All three parameters of FLIP measurements, DI, CSA, and minimum diameter are less after magnetic sphincter augmentation. More importantly, these two procedures are fundamentally different in terms of physiology, in the sense that MSA doesn't have any intrinsic relaxation capability. Following Nissen fundoplication, we would be still able to observe transient lower esophageal sphincter, a phenomenon that we won't be able to see following MSA. In addition, no interesting resting pressure exists after MSA. So these are the components of restricting force at the EGJ following MSA. Obviously, the magnetic force between the beads is the most important one. That force is 40 gram when the device is closed and drops to 7 gram in the maximal expansion of links. Undersized device can squeeze the esophagus and increase these restrictive forces. The native LES pressure also has a role as a component here. Tissue compliance of the EGJ is another factor. In patients with advanced reflux disease, we have restriction from fibrosis from advanced degree of acid exposure. And another topic which has been focus of attention of many publications is the fibrotic capsule that forms around the device. This component is highly variable and depends on two main factors. One is the host response, and the other one is the timing from surgery. And the other component would be a tight crural closure. Of all these factors, the ones that are modifiable are size of the device and tight crural closure. Crural closure is a component of all anti-reflux surgery, so we come down to size as the most critical element of anti-reflux surgery during MSA that impacts EGJ resistance. Therefore, there have been 2 studies that look specifically on the impact of size on the outcome of magnetic sphincter augmentation. This is a series of 540 patients, and the patients have been divided in 3 groups based on the size. Size 13 and 14 was recognized as a small, medium, size 15, and large consists of size 16 and 17. A favorable surgical outcome defined by at least 50% decrease in the Gerdau QL total score was comparable among the 3 groups. Persistent dysphagia, defined by a dysphagia score 3 and more on Gerdau QL dysphagia component, was also not significantly different, but you can see a trend towards higher degree of dysphagia in patients on whom a device size with a smaller size 13 and 14 were used. The Meester score difference reached a statistical significance, and the normalization of esophageal acid exposure was also significant. 82% of the patients with a smaller size devices had normalization of acid exposure, whereas this rate was only 65% in patients with larger devices. This is another study consisting of 350 patients, and with the same principle, they divided the patients based on the size and look at the outcome. The rate of persistent dysphagia with the same definition was not significantly different, but you can see a stepwise decrease in the rate of dysphagia by larger device being used. But need for dilation was significantly higher in patients in whom smaller devices were used. Nearly half of the patients in size 13 group required dilation after surgery. Normalization of acid exposure also didn't reach a statistical significance, but again, you can see the trend with 87% of the patients in size 13 achieving normalization of acid exposure. This is our own data. We look at the impact of the size on the postoperative EJJ resistance as measured by IRP. Again, you can see a stepwise decrease in the IRP as moving from size 13 to 16. The only exception is size 17 that behaves differently, and this difference reached a statistical significance. So based on these observations and the clinical experience of the surgeons, there has been a sizing protocol developed. And in order to choose appropriate size of the links, we use a sizing device and we place it around EGJ after dissection. Then we start to tightening this ring till it opens up. This point of opening is commonly defined as pop-off point and is expressed as the number of beats. Majority of the centers were using the size by going 2 sizes above this point. But the same centers, in an attempt to decrease the rate of dysphagia, started to size their device by going 3 beats above that point. But there is no study that compared these 2 sizing protocols to see if it really impacts the outcome or no. So we review our series of close to 750 patients who underwent MSA in our institution between 2013 and 21. We modified our sizing device around March 2018, and then we divided the patients based on their sizing protocol, and we look at the clinical and objective outcome at 1-year follow-up from the surgery. In this study, we defined dysphagia as a post-op score of 3 or more for the dysphagia-specific item in GERD-HRQL. As expected, this change in sizing protocol resulted in overall larger size devices being used, and the difference reached a statistical significance. But when we compared the outcome between the two groups, as you can see, patient satisfaction was very similar between two groups. 50% reduction in GERD-HRQL total score was identical between the two groups. Freedom from PPI, the MR score, and the rate of pH normalization was also comparable between the two groups. When we looked at different components of GERD-HRQL score, the total score was similar between the two groups. Regurgitation score, heartburn score, and also gas bloating score were also similar between the two groups. Then we focused on more dysphagia-related outcome. Rate of persistent dysphagia was almost identical. Need for dilation was similar. Need for frequent dilation, meaning 2 or more dilation, was also comparable between the two groups. And the device removal rate was also similar. So in conclusion, does size matter? Yes, it does. At this point, is the most critical element of procedure. An inappropriately undersized device can result in dysphagia. Similarly, inappropriately oversizing can result in both poor reflux control and also some degree of dysphagia. So MSA was born as a procedure that you would be able to get consistent results. There is not much variability in technique. This is the first time that we are seeing inconsistency in technique that translates to inconsistency in outcome. So the changing in sizing device from POP2 to POP3, at least in our series, hasn't resulted in lower rate of dysphagia-related outcome. Some explanation for lack of this difference. One is that there's definitely need for improvement in the current sizing protocol. We are not doing it correctly. There are some degree of subjectivity in our current sizing protocol. The other potential explanation is one size increase likely has no clinical significant impact. And more importantly, this emphasizes the complex nature of post-MSA dysphagia, which is the result of a multifaceted interplay between esophageal motility, device size, the variability in host response to implant, and most importantly, individual subjective perception of dysphagia. For those of who operated on MSA patients, you know that there are different group of patients compared to Nissen population. Any process related to visceral hypersensitivity is probably most prominent in MSA population, and part of this can translate to these findings that we had. Thank you.
Great. Take one or two brief questions in the interest of time. Thank you for that great talk. I will start off with a quick question. As you said, post-MSA dysphagia, this is something we all struggle with quite a bit to try to understand. Did you, when you changed your protocol, did you also at that time start implementing intra-op flip, as you seem to allude that it's very sensitive towards this, the restrictive aspect of assessing the EGJ?
Very good question, and that's a question everybody asks. Yes, we have looked at the endoflip data, and this is the area that we are far from being perfect. So we welcome any technology in the area. But there are some thoughts in terms of applying endoflip in the setting of MSA. One is if we are applying endoflip to guide measurements, this needs to be done before crural closure. Of all the steps of surgery, the one that impacts the distensibility is the most is crural closure. Whatever we do after that has very minimal impacts. The other thing, I'm not sure when it comes to endoflip in the sizing, we are looking at the correct parameter, the most useful parameter. We are looking at distensibility, whereas probably the more appropriate parameter in the surgical setting would be compliance. The software reports that is highly underutilized. So probably we should look at that. The other component is during the surgery, with all the manipulation, we are inducing so much peristalsis contraction that can impact the contractility and measurements. So it's a work in progress. Obviously, we need more tools to come to the point that we can have sizing more appropriately. But there is no data as of now about endoflip and sizing.
So have you gone back to POP plus 2?
And measure the, no, we have not.
Okay.
So basically, the other point about POP2 and POP3 is the company who designed the device, this is a sizing device everybody was asking. This is a newer version. From ergonomic standpoint, is much more advanced. But in terms of measurements, there's not a huge difference. There are so many factors involved when we are doing this. The angulation, torquing, acceleration, all of these changes that pop-off point. So it's not as objective as we are thinking, and company doesn't recommend POP2 or POP3. When you look at their language, they are recommending visual sizing. They're recommending make sure that links is in appropriate size with no compression of esophageal wall.
Great, thank you.
So only fitting that our last two speakers are the winners of the Early Career Awards. What better way to talk about continuing to stay on the cutting edge and moving the field forward with two initial presentations by established leaders in the field. As we bring up Dr. Carlson, I think I'm going to take some liberty on behalf of the rest of the executive committee of the board and the full board to apologize to Dr. Carlson for making him speak last, not once, but twice on a 3-day conference. So Dusty, please tell us about the future of FLIP from your perspective. And I will also warn the audience that he has the shortest presentation pre-prepared of all of the folks. So you're in for a treat.
All right, well, thank you, Mike. And thanks again to all of you for sticking around and for the invitation to be able to participate today. But yeah, I'm kind of wondering, like, if or how I read into this, where it's 2 out of 3 days, it's me between you all and cocktails. So.
Yeah, and the president who formed it, don't you guys work together?
Yeah, exactly. I got to maybe re-examine some things when we get home. But anyway, so yeah, so thinking about FLIP, and yeah, I was given this the topic of FLIP Panometry 2022. And so the starting point here was really kind of thinking about what we did with FLIP Panometry in 2021, which really was the time when a culmination of a number of years of work came together, where we had enough data to really look at FLIP critically and in a very rigorous fashion, try to validate really our classification scheme for looking at classifying esophageal motility and really using this tool as a diagnostic tool to help aid us in identifying esophageal motility disorders. And really that started with kind of reaching this point of data where we looked at the contractile response, secondary peristalsis, and we validated over 700 patients comparing it with primary peristaltic patterns on manometry. With EGJ opening, we moved away from kind of that classic Chicago classification-like approach of using a single metric and a single threshold, but instead use 2 metrics, use both the ostensibility index, but also the maximum EGJ diameter, and together using multiple thresholds, really looking at this as far as a probability of when EGJ opening may be normal or abnormal, using that to reflect obstruction. And ultimately, bringing those factors together, incorporating input from a great group of collaborators, putting together a working group to come up with this classification scheme. Whereas you see kind of differing from the Chicago classification, this isn't looked at in a hierarchical fashion, but instead about bringing these factors together and looking at how the contractile response and EGJ opening align and incorporate these pieces together to come up with when there's a high probability of normal peristalsis and a low probability of EGJ obstruction, this is going to identify normal motility. On the other end, when there's a low probability of normal peristalsis and a high probability of EGJ obstruction, this is something that's going to align with achalasia. However, even within the esophageal motility spectrum, this isn't a linear thing really. And we recognize that spasm kind of falls in a different dimension. It falls outside of this. And so even something that we looked at, bringing in these features independent of EGJ opening to identify these patterns. And ultimately, we brought this together and we looked at this, again, using the updated Chicago classification version 4. We went back, we reanalyzed the boatload of manometries. Half of these patients had time-bearing esophagram with tablet as well. But we could see that, especially at those 2 ends of the spectrum, when there was a normal flip, that over 95% of these patients didn't have a major motility disorder. This is a pattern on flip that effectively rules out a major motor disorder and maybe some scenarios where, depending on the pretest clinical probability, could be done without manometry. We can avoid putting patients through that test. The other important end of the spectrum is this one. Again, when there's a high probability of EGJ obstruction and a high probability of abnormal peristalsis, this was a finding that was associated with achalasia and conclusive EGJ outflow obstruction, abnormal manometry and abnormal time-bearing esophagram in over 90% of patients. And so together, really using FLIP to help identify motility disorders, maybe as a primary tool, but certainly incorporating this in to helping it use in a complementary manner to helping identify motility disorders, and by complementary, I mean using it as that full array of clinical data, the clinical history, the endoscopic findings, which are always going to complement the FLIP study, but also manometry and time-bearing esophagram in certain cases. And so, again, it's between me and you, Nolan Cocktail. So we'll wrap it up there. Email me with questions, or even better, come to the FLIP course tomorrow. We're going to talk about all this in much more detail. All right, thanks.
That was great.
I told you he was going to be efficient, but we're not going to let you off the stage just yet. As we get our course directors to come up and say some final words, give us a sense, people like the KISS principle, right? Keep it simple, stupid. They want to get the number, they want to get something, they want to put it in their report, they want to say this is what it is. So how do you find this sort of realistic understanding that life is not black or white here? How do we as practitioners, how do we as proceduralists who are going to be incorporating this and trying to share the findings with patients, with referring providers, with each other, how do we best document, how do we best share this information if it's along a spectrum? Is it just providing the numbers? Is it getting into the weeds and trying to say, well, this is what we think it means? How do you see us utilizing this breadth and this spectrum and that fantastic diagram that's no longer just yes or no?
Yep, exactly. And I think that was definitely a part of us in this whole process, was trying to make this simpler and really trying to hone in these classifications to having just the DI at the 60 ml fill volume. Really look at the contractile response and not trying to pick it up at each different volume and thinking, what does it mean if it's this or that, or if it changes, but looking at over the global course of the study. And to kind of bring it together to say, yeah, I think that even clinically, you look at it, if it's normal, if there's repetitive antegrade contractions, the EGJ opening is normal, you look at that with a high probability, this is going to be normal. The other end of that spectrum, there's reduced EGJ opening, the contractile response was abnormal, you look at that saying this is very abnormal. And if you'll afford me a gray area, I think that we have to look in the middle there and just notice that there are some times where you're going to say, you know what, I'm not certain this is normal, and I'm not certain that this is abnormal. There's something potentially going on here. This may be just a time where we're going to look at this and recognize some uncertainty and send a patient to do a manometry or a time barium swallow. And that's going to help give us a little more clarity as to what the esophageal motility diagnosis is.
So do you see us then putting manometry second to FLIP? I know that that's been out there for a few folks, that we don't go to manometry unless it's not a slam dunk on the FLIP. So is that where we're going? And is that in part why you have put out this gray area so that we can use other tools, but now we start with an endoscopically based technique first?
Yep, absolutely. And I think that it's definitely been positioned in a way and set up in a way that normal FLIP finding is going to be have a high specificity for normal motility and really to allow us to rule out major motility disorders. And if that finding is seen during an index endoscopy, especially again, this is all in that context, the endoscopy is going to appear normal, clinical history hopefully is supportive, but to really shift the focus that this is going to carry a chance of being achalasia of about 0%. So let's move to something else and look at reflux, look at functional syndromes, and definitely focus that initial management step there. But yeah, I think this is definitely an opportunity to avoid putting some patients through manometry. And even if it does identify that you would need to do a manometry, all these inconclusive manometries that we're left with, we now can look back, have this data to help complement and correlate everything together to reach a more firm clinical decision.
Fantastic. Well, I want to thank Dr. Carlson, Dr. Karillas, Dr. Ayazi, Dr. Nguyen, and my co-moderator, Dr. Damani, for a fantastic final session of the course. And we'll bring up our course directors for some final comments. Thanks to all of you for sticking it out, and I hope you enjoyed this last session.
Never got to.
Well, thank you, Mike. And is this working? We've reached the finish line here, but before we let you go, we want to say a few final thank yous and a few final comments. Number one thank you goes to Jonathan Kretschke and the people from ShowCorps who put on all this tremendous AV. They're the men in black back here. You can't always see them, but man, they did a fantastic job. I was so impressed with the audiovisual for this meeting. We'd also like to thank the program committee members who we couldn't have done this without them. It was truly a collaborative effort. As we've been told, a lot of monthly meetings, long, late nights, and a lot of great ideas from all the program committee members. We want to thank our industry sponsors again, because we can't do this without them. So a round of applause for them. We want to thank all the speakers and all the moderators for their great contributions to the meeting. And last but not least, we really want to thank all of you, not only for coming, but for your participation, for all the questions. And this society is all about learning from each other. So thank you very much.
And we'd like to repeat what we said at the beginning. This is a collaborative society. There's a home for everybody in this society. So the young people in the audience, the fellows, the trainees, please join the society. The meeting is going to be a membership benefit, and the society is going to put forth workshops and live hands-on programs throughout the year. There's one planned for January, a motility hands-on course. We're hoping to have a more expansive esophageal physiologic course over the spring. There is a bariatric course sometime towards the late winter. So lots of different membership benefits. We also have virtual offerings throughout the year. And I would also encourage our members to join DocMatter, which is the online community where you can communicate with each other and with faculty. Some of the talks and some of the comments from these talks will continue on DocMatter. So the didactic part of the program is ended, but there is a motility course tomorrow morning, a flip course there, that is, and there is a robotics course. But now it is time to have a little bit of fun. So,
and there's a video that's going to show here for those who want to stay around, and then the reception is going to be down the hall in the Sun Ballroom.
One last one. Do you have a phone?
So enjoy, everybody. Thank you very much.
Oh, yeah.
See you at the reception.
Oh, yeah.